it's very nice to continue.
Yes.
It's wonderful to meet all of you this morning. I do apologize for the technical issues we're having here in South Africa because we're having a lot of electrical load shedding because we have a base load generation problem in the country. But fortunately, I have an inverter and I was able to still join the meeting. Today we're going to talk about quite an important project in Lesotho, and it's very important because the project itself has had a very bad reputation, and it's been used, unfortunately, politically in a lot of environments in the Southern African region not to use PPPs to help deliver healthcare services. And I just want to make a number of opening remarks about it. The first thing is that it was a good project. It was a project, if approached properly, would have worked immensely well. And unfortunately to say, the majority of the issues that lay with the problems in the project lay with government. Now, I'll leave the main presenter to look at some of those things. But on the other hand, I do want to say that in South Africa, we have about half a dozen very good PPP projects, which we call co-location projects, which I'm happy to elaborate on further. And I'm currently working on a PPP project, which it's a retendering of a PPP project for a literally state-of-the-art healthcare facility in our province of KwaZulu-Natal. And while I can't give you all the details because there's still negotiations going on and evaluations going on, if you would like, I can give you some broad outlines of it in order to give people a sense how well PPPs in healthcare can work. And I'd like to make a broader statement, if I might. Everybody talks about the lack of infrastructure development, not only in Southern Africa, where I am in SADC, but on the whole African continent. We constantly hear the number of about 150 billion US dollars every year that we need to develop new infrastructure. But the reality is that number shortfalls by about another $50 billion just to maintain the infrastructure that we actually have. So we're looking at a roughly $200 billion per annum on the continent of Africa. And governments simply do not have that money. There's no treasuries and departments of finance that can fund that kind of infrastructure. And the reality is we would have to look to about at least half that money coming from private sector sources, either through direct private sector investment or through blended finance, which is becoming more and more popular, and obviously through typical project finance processes. And just to give you a very short background on my experience, so you have some faith that the things I say to you have some validity. For 10 years, I was the Director for Business Development in the National Treasury PPP unit in South Africa. I then did a very short stint with the Development Bank of Southern Africa, as a senior project developer, so to identify projects and then filter them through to see if they were worth going through to feasibility studies. And for the last 9 years, I was the head of the SADC PPP network, where I helped develop PPP projects in the SADC region, ranging from actually IPPs, tourism, transport, and of course in the healthcare sphere. So I do have a lot of on-hand experience, and what I'd hope to do today is for us to share that experience and bring it to bear on the healthcare project we're about to talk about today. So I hope that we have a fruitful discussion and a learning discussion, because I think I would like to thank Dina for the meeting, because we don't have enough of these kinds of meetings where we actually have sharing and learning experiences, because essentially that's the way that we're going to get things going. And the last thing I want to talk to you about, and perhaps mention in the discussion period, is why PPPs are not as popular on the African continent as they should be. And some of them are just hard truths. And I think it's time we were much more honest about them. So yeah, that's my short introduction. So I'd like to hand over to the presenter, and maybe she can say a few things about herself and some of her observations on the project that she's done her evaluation on. Thank you.
Thank you very much, Kogan, for that introduction. Am I audible?
Yes, you are.
Oh, great, thank you. My name is Ntoetse Mofoka from the Mountain Kingdom of Lesotho. I had the privilege to work on this project, but now it's 3 years since I left the Ministry of Health and joined the Central Bank of Lesotho. But in 2020, I enrolled for a master's in development finance. So since this project has been of interest for most of the people, especially the challenges, I found it worthwhile to undertake as part of my research to fulfill my master's, to undertake a case study on this project, of which the results can be shared with the community out there. Some of the challenges that I'm going to talk of that were revealed from this study are already out there, but maybe the root causes of why the project faced such challenges have not been really articulated out there, of which I wanted to share with the community. I don't know, but the project that we are talking about, I thought Kogan will give that little bit background, replaced the government old referral hospital that was referred to as Queen Elizabeth II, because it was then the infrastructure was no more good, and it was now costly for the government then to maintain the facility to provide quality healthcare services. So following a number of studies that were conducted, the government decided to go for PPP, bringing in the private sector to provide the healthcare services and to finance the project. This project was, I loved, as Kogan talked about, the state-of-the-art hospital that they are working on, that this is one of the projects that as it started all over the world, it was marked as the state-of-the-art hospital, of which, if it was successful, the aim was to replicate it in sub-Saharan Africa. But anyway, here we are, the contract has been terminated with the operator. I will talk of the overview of this project and how it was structured. And then I will touch on the objectives of the study that I'm sharing the results of, and the research design, though I'll not get into the details of that. And of course, the main issue is the findings of the study that I conducted on this project. And of course, lastly, we'll talk about the recommendations. Before we move on, I wanted to make a disclaimer here that the views presented here does not represent the views of the government of Lesotho nor that of the Central Bank of Lesotho in any way, but the findings of the study, as I indicated, that was undertaken by myself in fulfillment of my master's degree in development finance. But of course, as a prerequisite, the study was cleared by the Minister of Health Ethics Committee. Thank you. Okay, this is the project that we are talking about, Queen Mamhato Memorial Hospital, which was run by Tepong Pty Limited. The objective of this project was to improve the access to medical healthcare services, and of course of higher quality. And also it was to reduce the referrals for medical services to South Africa, because the project, the hospital that was replaced by this one used to refer most of the patients to South Africa for medical care. And like I said, due to the issues of capacity and of course the state of the hospital then, which did not even have quite good equipment. So most of the medical services, the country found itself referring to South Africa. The company that the government got into contract with Tepong Pty Limited, it was an SPV. As you know, that PPPs normally are run through the establishment of an SPV. So the contract was signed in October 2008, and I think the financial closure was in March 2009, and even the construction started somewhere in early 2009 after the financial closure. This was 18 years contract, which was to run from then up to 2026, but the contract was terminated last year, which was 5 years earlier than the planned contract end date. This hospital started operations on the 1st of October 2011, and the costs were plus or minus 1.3 million rands or maloti, which is equivalent to around 153 million US dollars with today's conversion. And the government also put in the contribution to that of around 486 million, with the private operator, which is Tepong, having invested 804 million, of which composed of equity and debt from DBSA. This was an availability PPP, not a user
politician.
Can we please mute our mics? This was an availability PPP and not a user PPP. So even the collections that were made at the hospitals, the operator was not keeping them, but was returning them to the government. Otherwise, it was through the unitary payment. It is a 425 bed hospital with that capacity, of which the 390 beds were for public and the 35 earmarked for private services. The project also refurbished and expanded 3 filter clinics around the area. The contract provided for the minimum and maximum patients that the service provider, which is the operator Tepong, could attend to, with the minimum inpatient be 16.5, and then the outpatients. No. I'm sorry, there's a mixed up of figures here. The minimum required, the minimum patients was 16, inpatient was 16.5, with the maximum number being 20,000. While the minimum for the outpatients was 258,000 patients, with the maximum number being 310,000. Yeah, I'm sorry for that mixed up of the figures, but there was minimum and maximum of the inpatients and the outpatient volumes that the operator should attend to. The transaction advisor for this project was the International Finance Corporation, and the performance monitoring was to be done by the Minister of Health, of course, as the beneficiary of the project. And the unique part of this project was also the inclusion of the independent monitoring, which was a South African-based company that would come every quarter to assess the performance independently of the operator. Okay, this is the structure of this project. There was an agreement, PPP agreement between the government and Tshepong, and there was a financing agreement between Tshepong and DBSA as a lender, and also the lender's direct agreement between DBSA and the government. Tshepong had subcontracts, the other one be for construction of the facilities, and the Netcare Hospitals was the management company, while Heart Facilities was undertaken by a local company by the name of Botle. Tshepong was a consortium of 5 companies, of which 3 were local companies and 2 were South African-based companies. The South African-based companies was Afrinai Health and Netcare Hospital Group, which was even the major shareholder in this project. While the locals was D10 Investment, Excel Health, and Women Investment Company. I'm sorry, this seems to be running very fast. Having provided this overview, I will now share the results of the investigation that I did to dig into the root causes of the challenges that this project faced during its operation. First of all, the objectives of my study was to investigate the root causes of the challenges, of course, that were faced by this project, that everyone was looking up to, and all Africa was looking up to, and also to determine the factors that affected the success of this project. And since the data collection coincided with the time when the project was being terminated, I also went further to determine the possible reasons for early termination of the contract from the interviews that I conducted. Who did I talk to? In terms of the interviews that I collected, it was a total of 19 people, of which 11 of them were the current and the former Minister of Health officials. I'm talking of the current and the former because you'll find that some of the people that had information or have worked with the project were no more within the ministry, but were still willing to provide their views of what may have went wrong and why. And also within this 11, there were the former PSs, at least 3 of the principal secretaries that served within the Ministry of Health during this during the contract. Also the Ministry of Finance, there were 3 people that the interviews were conducted with. In terms of Tshepong, in as much as the shareholders were 5, it was a consortium of 5 shareholders. The interviews were only conducted with 3. And what I want to bring to the attention of the participants is that one of the shareholders that I did not manage to get to interview, which is even critical, was Netcare itself. The reason being that by the time when the interviews were being conducted, that was when Netcare was handing over the hospital to the government, so it was hard to get that, and one of the local shareholders. Otherwise, I managed to get one of the South African shareholders from Afrinai and the 2 local companies' representations. And I also conducted an interview with the former consultant with the Ministry of Health, who was engaged to help the ministry with the capacity building on this project. And of course, the former Minister of Finance, who the project was even conceived during his tenure as the Minister of Finance, he managed to give me time to have a chat with him regarding this project. One other data collection tool that was used was the review of the documents, and mainly the reports, not the financial models, not the confidential documents, but the reports that are open to anyone. The data analysis was done with the assistance of NVivo. It's a tool, is a software that people who have done qualitative research will know about it. So what came out of this study? What came out is what most of you who may have already heard about the project or read anywhere would come up clearly: the high project cost to the government. The reasons for this would be unpacked a little bit later, but having talked with the people and analyzing the data, the main issue has still come out as the high project cost, which government found it now no more affordable and not sustainable. And also the other clearing issue has been the disputes among the parties. The parties, I mean, the consortium parties, the shareholders internally themselves among Tsepo, and also the disputes between the government itself and its partner Tsepo. Those are the issues that all the participants raised as one of the major challenges that the project have since been faced with. But the question is, yes, we have had this project being labeled very costly to government, but the question is, what has led to this high cost? It came out clear from the study participants that the main contributing factor to that challenge was the poor referral system. How? In that this was the national referral hospital that was being fed by the district hospital across the country, and of course, even the private facilities. But it seems like the government did not have the clear protocols on how referrals should be done, to the point that most of the participants were saying that is why you would see even minor cases that under normal circumstances, one would expect them to be attended to at the lower level of care. Now they were seen to be referred to this national referral hospital. And this indirectly led to the high cost, because the demand parameters that have been set, that I talked about, of the maximum number of 20,000 inpatients and the maximum number of 310,000 outpatients. The minute the operator exceeds that number, the contract provided that the operator can now charge government extra cost on top of the unitary payment. So these referrals, that seems to be uncontrollable. And of course, when you talk to all of them, they were saying from the beginning of this project, we have always been having this poor referral system. So why was this poor referral? Not necessarily why was this referral system bad. The other issue that was raised by the participants was that sometimes it's not necessarily even the poor referral system, but lack of capacity of the district hospital in terms of the numbers of the medical doctors there and the nurses, but also in terms of the infrastructure at the district hospitals. That was raised as maybe one of the reasons why we ended up, I'm sorry. I'm sorry about that. I'm in the boardroom that when there's no movement within the boardroom, the lights switch themselves off. Sorry for that. So the participants in the study also came up with this, that lack of capacity in the district hospitals have also contributed to the high cost of the project. Why? Because the hospital now ended up experiencing high patient volumes, finding itself almost every year exceeding the 20,000 maximum inpatients, exceeding the 310,000 outpatient volumes that have been stipulated in the contract, and therefore as such having to charge the government more for that excess pay services that have been provided. But the other issue that they raised was the government itself, the lack of capacity to manage the contract itself, which they felt like of the staff that were trusted to manage this contract, they were not capacitated enough to manage this contract, such that in such cases, they end up being intimidated by the operator and then not even doing much on their side, which led to inadequate project performance monitoring. Because as we know, the minute the government brings in the private sector to undertake the service that is normally run by the government, that is not the end of the government's responsibility, but that is the start of its major work to ensure that it gets value for money from the service being provided by the private sector. And that can only be done through proper, frequent project performance monitoring, which, due to lack of capacity that the participant raised, seem to have also been one of the root causes that they said may have led to the challenges that the project faced. Also, the other thing that came up clearly as I was talking to the participant was lack of project ownership. Most of the people that I talked about felt like this project was, the government was not owning it much, in that they were pointing, for example, that as a sign of ownership, they would have wanted to see government being able to establish and capacitate the project, the PPP unit. But unfortunately, if I may share, it came clear from this study that the PPP unit was only staffed with 2 people from the Ministry of Health end, while from the Ministry of Finance end, I think it was only 3 people that at least are conversant with this project. So they felt like a sign of ownership and commitment by the government, the first sign would have been of establishing a fully fledged PPP unit staffed with right skills to undertake the government role of performance monitoring in order to get value from this project. But also what came up very clear was lack of the knowledge and understanding of the project itself. Some of the participants were coming up clearly to say, even myself where I am, I'm expected, because of the nature of my job, to know most of the PPP project terms, the contract terms, but I don't know even the terms that are used there sometimes, even when they will make an example. Even if IFCs or World Bank, they're trying to explain to me what this means, I don't understand the PPP. There's even no, like I said, capacity that has been built for me to undertake my responsibility. So they were pointing to the lack of knowledge and understanding of the PPP concept itself as one root cause of the challenges that this project had. This was even seen with the interview with the directors within the ministry. That one would expect, based on their role, to understand some of these basic things. Commenting, for example, as if the project is supposed to operate like any other, not understanding that in PPPs, we talk of performance contracts and not normal contracts where we focus on the inputs, but here we focus on the outputs. But the sign that people didn't understand, you'll hear the comments saying, Tepon did not have the right number of doctors or the right number of nurses. But if people understood, one would not expect such comments from them, because they would know that in terms of the inputs of what the operator do is not the government major issue, but the government is more concerned about the quality of care that it is getting, as in how the private operator gets that. It is none of the government business. But due to that lack of knowledge, you hear such comments. And you also hear comments that were saying, Tepon, there is provision for dialysis there, but they're not providing it. There's provision there in the hospital for oncology services, but they're not providing it. That was one of the signs to me as an interviewer that these people were not conversant with the contract itself, because in as much as those provisions were there in the facility when it was constructed, they were not covered as part of the operator's responsibilities, hence why they were still being referred to Bloemfontein. But as one of the candidates that I interviewed said, CEPOM was just meant to collect the statistics of such, for instance, cancer patients, just so that when government later in the project implementation decides to provide such services, it will be knowing at least how the numbers stand, whether it's still worthwhile to refer such to South Africa or not. But this was not surprising that it was confusing people as to why maybe some of the services are still being referred to South Africa, because one of the objectives and one of the selling ideas when this project was being sold out was that it will reduce the referral to South Africa. But then people were surprised to see, oh, the government already continuing to send people to South Africa. Little did they know that, yes, the contract had provided that certain services the operator should not provide in the country. So it meant they will still need to refer them. What also came up as the root causes of these challenges was the environment within which the project existed. As I may mention, this project, like indicated, the hospital started operations in 2011 in October. And I think a year later in 2012, we went for the general elections and there was change of government. 2 years down the line, again in 2015, we went back to the general elections. There was change of government. In 2017, again, 2 years down the line, we were back in elections. And we know how PPP projects are sensitive to such changes. So that came as the cause that people felt like maybe if the environment was very conducive, the project may have seen its life to the end. And the other thing is that as the political parties change, they come with different management, they come with changes in leadership, which the participants have indicated as one of the things that has really affected the project, in that even the challenges that arose during the project implementation or operation could not be resolved because of that frequent changes in leadership positions within the Ministry of Finance and the Ministry of Health. The other thing that came up was unavailability of the PPP frameworks. The Lesotho government got into this project with no frameworks in place, but I think it was undertaken based on the public procurement regulations of 2007. So some of the people felt like maybe if we had the legislation in place, the frameworks in place, we would have not experienced what we experienced in this project. Though others had different views on that saying, those were just going to be papers in black and white. They were not going to implement the project. They were not going to monitor the project. So they said we can't guarantee that having them would have resulted in different outcome. The other issue that came up was the lack of government commitment. People were feeling like there was no commitment in that. Like I said, other than that, even the literature says that one of the signs that the country is willing to embark on PPPs is the establishment of the PPP unit within, in most cases, the Ministry of Finance. People felt like maybe there was no much commitment looking at the way we have run this project, in that even though the PPP unit was based in the Ministry of Health and not necessarily in the Ministry of Finance as in most practices, the staffing of that unit was not convincing for most of the people that there was any commitment to making this project a success. On this one, I want to also mention what they were saying. They were saying, for example, the World Bank Group and also Harvard Leadership Program tried to came in to help government to solve the problems that were being experienced, but the results were not positive. There will be those initiatives put in place to try to control the referrals in an effort to reduce the cost. But at the end of the day, none of the initiatives that these organizations came up with ended up with positive results. So they felt like maybe there was not much commitment to really solve these problems. Okay, then in my questions, I tried to assess the factors that can come out that may have impacted the success of this project. Poor stakeholder engagement came as one of the factors that affected this project. People felt like there was not much engagement that was done. I'll give an example of doctors. They would say, during the design of this project, you just hear on the passages that there's this new project coming up, but as medical doctors, we didn't feel included to help and contribute in the design of the project, such that some of them were even saying, had maybe we be given the chance to participate fully in the design of the project, or even throughout the project phases, we would have not advised to have the filter clinics as part of the package that the private operator should work on. So poor stakeholder engagement came as one of the factors that affected this project. People felt like, okay, there was transaction advisor here with certain high-level people within the Ministry of Health and the Ministry of Finance, but not engaging us down there to get our views on how the project should be designed. One other thing has been the lack of transparency that came up clearly. Lack of transparency came from both the shareholders' perspective and also from government. Government felt like the way Tshepong was doing business was not transparent to it, in that most of them were giving an example that it was hard to get audited financial statements. It would always be a struggle to ask Tshepong to provide us with the audited financial statements. So we felt like there were things that they were hiding from us. We feel like even the numbers that they were claiming to have seen were not actual numbers that they have seen. So they felt like there was not transparency at all. While the shareholders themselves, the local shareholders, felt like there was no transparency in the way the management company Netcare was conducting business. Those are the things that came up clear, that transparency was not there in this project. I know we normally emphasize the need for transparency during the procurement process of this project, but that is not the only stage that we need transparency. Same as the stakeholder engagement, we need such things throughout the project implementation, because when there's transparency in a project, it enables the next party to make informed decisions. But the minute one party feels like, I don't have enough information and I don't trust what I'm getting, then we are likely to fail. Lack of trust also came up very clearly, that the government didn't have trust. And of course, that would be attributed to transparency, that they were doubting. Then they ended up not trusting anything from Tshepong. And other than that, even the shareholders themselves were complaining about having no trust on Netcare, on how it was conducting business. All of them that I interviewed indicated that they even requested a forensic audit with the management of the contract, which is Netcare. And that is a clear sign that there's no trust among the shareholders. The other thing has been the poor relationships. It happened to appear that this relationship between government and Tshepong was very poor. It was just a like a marriage of convenience, other people would say, because the minute in a relationship, people do not trust each other, are not transparent to each other, it says that poor relationship is likely not to last long. Some people were even saying they don't even understand how the contract survived thus far, looking at the way the relationship has always been between these two parties. Like I indicated that I conducted the interviews during the time when the government had clearly indicated that it is terminating the contract. I had to tap their views on the possible reasons why government decided to terminate this contract. And of course, the high project cost was coming from everyone that the government couldn't afford to maintain this cost and sustain them until 2026. So it had no option but to get out. Some other views was that Tshepong had fired then plus or minus 250 nurses. In 2021 February, the nurses at Tshepong, at QMMH, the Queen Mamhato Memorial Hospital, which is run by this one, that is run by Netcare and by Tshepong. The nurses went on strike for almost a month last year in February. And then sometime before end of March, that is when government announced its intention to terminate the contract, though it introduced the management in August last year. But they served that day, they noticed Tshepong sometime in March. So most of the people felt like government terminated this contract because Tshepong fired more than 200 nurses, and that, of course, we know how it can be politically. The reasons why these nurses went on strike was that they were complaining about the salaries that they were getting at Tshepong, which was not the first strike. They've been going on strike on and off, but then this was the major one, of which Tshepong ended up firing more than 200 nurses following their failure to report to work after the court order in that on that. So they didn't report to work, so Tshepong decided to get them off. Then government, most of the people felt like, okay, it got now a chance to say, you don't even have now the necessary resources to run the hospital, because you can imagine the impact of getting off 250 plus or minus 250 nurses at the go. What do you do to the services that you provide? So government felt like during this period, the services have suffered, so we can terminate this. These were the reasons that were raised by the participants in the study. Some felt like it was a political interference, and their reason was the way the termination happened, saying it was not a strategic termination or move. The way it was conducted has made them feel like it was more of a political interference. But the major issues that everyone raised was high project costs that the government could not sustain anymore, and the firing of so many nurses at the goal. When I'm here, I realized I may have skipped the slide where I was going to talk about this internal, I talked about this, but I didn't get much into this disputes. The disputes that have been experienced in this contract between the shareholders and the government, between Tshepong and the government and shareholders internally, not much has been disclosed by the participant as to what the dispute entailed in terms of between government and Tshepong. But what most of them highlighted was that, among other things that were in dispute between government and Tshepong, was the very same issue of the salaries that was paid to the nurses at Tshepong, which led to the strike. Otherwise, they did not disclose the details of the disputes. In terms of the shareholders' internal disputes, they also did not get too much into the details, but what one got was that the disputes were mainly due to corporate governance issues, with the local shareholders not being satisfied with the way the management company Netcare was conducting business. So the other issue that was of contention among the local shareholders was that of the dividends, because up to the time when I was collecting the data, the local shareholders that I got to interview indicated that there had never been the dividends have never been declared by the management company. So that was causing a lot of rise within the consortium. And the other thing that they mentioned was the share dilution. The contract between government and Tshepong was for Netcare at one point to dilute some of its share to local shareholders in an effort to build a local economic as a local economic empowerment strategy. But it seems like that has not happened since, as they indicated, that was supposed to have happened in 2016. But up to the time of termination of this contract, Netcare had not yet diluted such shares to local shareholders. In trying to understand what may have led to that, one shareholder indicated that he feels like it is the issue of contract interpretation, in that the contract just says that on the certain year, Netcare, you should dilute certain number of shares to local shareholders, but the contract have the gray area in that it doesn't say whether this shares are being at the cost or not. So that is what one of the shareholders indicated, that the issue is now, are they free? Are they being sold out? That is what they brought in as one of the issues that have been held in this, to say, where they say Netcare was saying, I can't give you these shares free, you have to buy them. But they were like, there was never no where it has been mentioned. And this made me to feel like this is one of the lessons that maybe we should take to try to make our contracts clear. I know the law of contract says there's never what economics of contract says there's never a complete contract, but some of the things have to be really clear to avoid unnecessary disputes. Or the other thing that now I remember, the disputes between government and Tshepong, even though they were not really detailed much, there was a mentioning only that the disputes that we have with Tshepong are mainly around interpretation of the contract. So that calls for practitioners out there to be a little bit more vigilant in terms of how they structure and draw down the terms of the contracts to make them not susceptible to number of interpretations. Otherwise, after this, having conducted this study, what one can recommend or what we can take from Lesotho is that it's very important to invest in the preparation of health systems if we are into any PPP, health PPP project, especially the referral hospital PPP projects. The minute we enter into such, or we design such projects, or think of solving any country's problems by bringing in the private sector to provide the referral hospital services, we should really invest in the preparation of the health system, to prepare it in terms of the skills, to prepare it in terms of the equipment, to avoid experiencing the same thing. Because it seems like in Lesotho, the referring system, the districts were not well prepared to come and operate properly with this new project. if the hospitals in the districts that will refer here would not be having equipment and necessary resources, it says then chances were high that we would end up seeing a lot of people being referred to the referral hospital unnecessarily. And the referral system should also be a key in terms of being prepared to make sure that our referral system in such setup is very clear to avoid burdening such projects. Lesotho have also made us aware of the need for the procuring entities to have clear policies on staff remuneration packages where the private sector also provide healthcare services, like we did in Lesotho. And I don't think it only applies to healthcare services. Any case where the private party that comes in to provide any service that was previously provided by government, I think it should be very clear on how remuneration packages would be to avoid experiencing things like this, because what came out clear from this one is that government along the way in 2013 reviewed the salaries of the government employees across the board, including the healthcare workers, while Tsepon's staff salaries remained the same. And the operator was like, in my financial modeling, in my projections, I didn't foresee where government will restructure the salaries. So that became a mess that ended up with strikes, with the nurses going strike day in, day out. Building the capacity cannot be emphasized with regard to the public sector. That is said in any platform of the PPPs, that it seems like the capacity of the public sector is really, really needing more attention. And like I said, I think we need clear and precise contract terms to minimize the risk of misinterpretations that we saw with this one. Of course, stakeholder engagement, continuous stakeholder engagement, not only ending at the design of the project, which even in this case happened not to have been done thoroughly, with people complaining of having not been involved. We don't want to see that. Let's be patient to engage stakeholders throughout the projects in the future project that we are to design or that we are already implementing. The other thing is the disputes. We can't run away from disputes. Disputes will always occur anywhere. They are very likely to happen in any PPP project, looking at the complexity of the structures of the PPPs that have so many parties with different interests. So disputes, we can't run away. So let's try by all means to resolve them as soon as they arise, because what one sees is that most of the disputes that have affected this project didn't happen a year ago, 2 years ago. They have happened as early as after a few years of the operation of the facility. Thank you very much. That is the end of my presentation. I would welcome the comments or the need for clarifications. Thank you very much. I hand over to you, Kogan.
Am I audible now?
Yes. You are.
Okay, thank you. Thank you for that excellent presentation. I think it was extremely comprehensive, and I can see that you did a lot of research to try and look at some of the issues relating to the PPP. If I might abuse my position as moderator for a second or so to perhaps raise issues people have brought up in the comments and the chats, and to try and get an holistic view. I mean, I think one of the things that you raised, which in my mind is critical, is the capacitation of the public sector. One of the key issues in Lesotho is, and in fact, I know this for a fact because the Ministry of Finance had contacted the SADC PPP network, and we had engaged a private sector company, Deloitte, to set up a structure for the Lesotho government, which looked at a PPP unit, what kind of capacity it would need, that it should, as you rightly say, sit in the Ministry of Finance, because that's ultimately the place where the long-term financial commitment is going to be signed, right? So the Ministry of Finance has to be extremely clear about what its costs are. That was the first thing. One of the other problems we got with the return of the feedback from the Ministry of Finance is we said, if you want these skills in a PPP unit, this is the kind of remuneration you're going to have to provide for these types of skills. And there was considerable reluctance to make those budgets available to pay the people that were needed. The second thing is that the PPP unit should be the nexus of where the skills sit, so that when there are issues, they can be there to guide the line departments in terms of how the PPP is being conducted. And remember, the other thing is there should have been an absolute view on the affordability limit on the PPP. And really, one of my great problems with PPPs in emerging nations, where there isn't a lot of PPP skill within the public sector, is that the private sector will take advantage of government. So, for example, when the affordability limits were starting to be breached, that should have been clearly communicated to government, and a plan should have been put in place to bring those costs down, so that they were in the affordability limit of the unit repayment. Because that's very important, because if you talk about one of the, and government is not blameless in this environment, because the places where people were supposed to be referred to the PPP hospital, you talked about the infrastructure, but there were two other things. One was the quality of the healthcare that was being provided. And secondly, oftentimes those government facilities simply did not have the pharmaceuticals that were necessary to treat the patients. So obviously, what would you do as a citizen? You'd go straight to the place where you could get the best healthcare and not have to wait in line all day to do that. And the other thing was about the firing of nurses. I think one of the things that there should be written into PPP agreements is the not ability for the private party to rationalize the workforce. This is important because it's also a political issue. And you don't want a situation in which people are saying, but look, we're handing this over to the private sector, and yet they're firing nurses, and they don't have the doctors, etc., and so forth. And in the discussion, one of the other things I'd like, because people have also mentioned it in the chat, is the importance of contract management. So if you don't have people fully capacitated within government who understand how to manage the contract with the private party, how to impose penalties when they're required, because the thing about a PPP, obviously, is that we know is that it's an issue of us sharing risk with the private sector, and where the private sector does not provide the services it's supposed to be providing, it needs to be penalized. I mean, for example, the point you made about not being able to get audited financial statements is simply unacceptable. in this environment. So we need to have a situation in which we have capacity, but we know exactly what we want out of the project and how it is to be delivered. And quite frankly, the disputes within the private sector consortium are none of government's business. You've got a service to provide, and if things were not going well, government had step-in rights with the direct agreement with the banks. So these are a number of the things I think we should touch on, and any other issues that that people have. If you don't mind, I'll just look at the chat and see if I can just ask people if they would like to make any comments on the chats that they've contributed. And maybe I could, just because I know him well, ask Andre Kruger to make a few comments.
Hi,
Andre,
hi,
are you still there?
Yeah. Hi, colleague. Can you hear me?
Yes, I can hear you.
Thank you, Kogan. Appreciate the opportunity, and well done to the presenter. I think it was well done. It's obviously a difficult project since there have been disagreements between the parties over a number of years. So I'm sure it will be very difficult to capture everything that was said and done. And it's like, I suppose it's like a marriage going wrong. There's always two parts to the story. But maybe just to highlight, there was also another question in the chat that I think is relevant to this case. The medical services provided by the private sector consortium definitely benefited Lesotho significantly. There were some reports issued that specifically addressed the increased health position, and there's some detailed statistics about about those statistics. So yeah. From a health perspective, the project was probably very successful. I guess it was about the institutional arrangements between the parties. The other comment I can just briefly make is that the IFC did appoint an external firm to train both the department, the National Department of Health, as well as the Treasury people on PPPs at the start. So the project management team was trained. A few years ago, I'm not really sure exactly when, our company also did bid to retrain the team, because what was found at that stage, if I remember from the RFP that was issued, is that there was nobody left in the Department of Health that knew anything about the project. So what happened is the IFC then appointed another firm to retrain a larger group of people to try and maintain that knowledge about the project and be able to communicate effectively. So I'm not taking I'm not saying the private sector was always good or the government was always bad, that type of approach. It was just very difficult for the private sector to communicate with government because of the new people coming into the system on a continuous basis. One critical thing, I think, Kogan, that you also mentioned, or that somebody on the chat also mentioned, is the percentage of the total health budget that was allocated to this project. Initially, I think the target was that it should not exceed 37% of the annual health budget. And at times, it actually exceeded that 37%. So maybe that's a very important principle, is that when we get involved in PPP projects, we always, these projects don't stand on their own. There's like we have seen, the referral clinics, the available money within the Lesotho health budget, etc. There are many other related issues that one need to take into account. So maybe in Lesotho, the percentage of the health budget allocated to this project was maybe too big. That is my subjective opinion, obviously not being that close to the transaction. It's a pity that the project did not continue until its end, but I suppose this is what it is. The parties did differ. There were differences between the parties, but there are many other good examples of very successful health PPP projects around the world, and the international organization, I forgot their name now, that is also involved in delivering this session, have got very good examples of health PPPs. So I don't think we should throw out the baby with the bathwater. And maybe as the presenter also said, that we've got to learn from this, and we must just try and be better in developing a next project. Thanks, Kogan.
Yeah, Andre, just a couple of things there. So if you look at the Nkosi Albert Luthuli Hospital in KwaZulu-Natal in South Africa, which has been, in general, quite successful. That takes up a quarter of their annual budget in unitary payments for that project. Although I think that one of the other lessons that we need to learn in terms of doing healthcare PPP projects is co-location hospitals. Because one of the things is that those co-location hospitals that we've done in South Africa seems to have been, I mean, a number of them are being reassessed, where we take people who have private healthcare insurance, we have government contributions, and then assessments of poorer people who need to have access to healthcare and what they can actually afford. And combining those sources of income make the project sustainable. So I think, you know, one of the things is not just about the percentage of the amount that it cannot exceed within the department's budget, is certainly the long-term financial sustainability, and actually to re-look at what the output specifications are, right? So when the feasibility study is done, let's look at the output specs, see how they can fit into the budget, and see what is actually necessary and what is not necessary. Because I know, for example, having worked in Botswana for so long, there are private hospitals, not necessarily PPPs, but a lot of the more complicated or complex healthcare services are then outsourced to South African hospitals, right? So we'd have to look at a sort of regionally integrated way of helping people identify how healthcare services can be delivered and in what way. And I mean, and to be completely honest, you know, the shortcomings in the healthcare services in Southern Africa in particular have really been shown up during the COVID crisis. We were just completely unprepared, right? And hospitals were overwhelmed in terms of providing healthcare services. So, I mean, I think there are a number of complex things, but the point I'm trying to make is, in other parts of the world, while healthcare PPPs have been quite successful, I think we need to sort of try and, you know, tweak those models to fit what we can realistically deliver through participation with the private sector. I mean, I don't know if there are any comments about those kinds of things, or the comments that Andre has made. And anybody is open to making a comment or asking a question. Nothing. Okay. Well, look, the other thing then, if I could, again, abusing my position as the moderator, is that it was only after 2012 that we were requested to help set up a PPP unit. We even got draft PPP legislation done for the government, and quite frankly, there was a lack of commitment to trying to get that in, and I'm not certain if there could be a comment on what that lack of commitment was. Was it simply a change in government? Because you did mention a number of different elections. However, the reality is a PPP is a long-term contract, and regardless of who is elected or not elected, the integrity of that contract should be upheld.
Kogan, just a heads up. There's one or two people with their hands up that want to come in for.
Okay, I can't see them. Could you?
Okay, Kogan, if I can go, it's Michelle.
Okay, hi, Michelle.
Hi. Just a thing, I mean, we ran the PPP dialysis from a dialysis perspective in SA, and that was a 13-year contract.
Yes.
Surely with this whole, and maybe this, the very good presentation, but with the penalties, there should have been very defined penalties with such a value of a contract, and considering the terms and condition and the length of the contract. You guys said there was an external moderator that was hired. And I just want to know, with the whole monitoring process on this quarterly basis, some of these things that were not being adhered to from a contract perspective, these things should have been picked up then already, instead of waiting for such a long time to say, okay, we've now reached an area of dispute. With these things not addressed then and corrective measures put in place. Look, I do understand to say, yes, Lesotho probably didn't have a proper PPP framework. And that's, one of the challenges we have in Africa across the board. Coming from an SA perspective, I think we have a very strong PPP perspective. And, working with the guys on the project I did, I saw that. But the thing about PPP, I always say, is the skills transfer. And knowing that the guys were going into Lesotho, this was lacking the skills transfer in the sense of government being trained. Yes, people do come and go. If I just take the project we had, I think I must have went through like 10 CEOs in the 13 years we were there. Or maybe
Yes.
I'm exaggerating. But it's still somehow the skill transfer and identifying these problems early. And here for me, it was you had an external company coming from SA monitoring this. And these were the things that should have been highlighted already early, when they started picking up these problems. One, that's my one comment. Secondly, from a TA perspective, they knew there wasn't a PPP perspective, a framework in place here. These were the things that should have been addressed, I think, already from an implementation perspective. That these was the risks, because the thing about a PPP is the risk sharing, and these risks should have then already been addressed. So that when you have the final project in its form and we're going through these phases, these risks have been identified and we have a plan on how to resolve them. That's just it from me. Thanks.
Yeah, I think, look, I think that's very important. And from a point of view of external people coming in to look at projects, one of the lessons I think that we've learned early on in the PPP process in South Africa is that once the project starts, from its inception, from its actual inception, where you appoint transaction advisors and you start the feasibility study, contract management should already be in place, so that you have a number of contract managers who actually understand the whole process from beginning to end and are not given a contract when we reach financial close. right? Because that doesn't help, right? Because then there's a lack of institutional knowledge. And there should be a transfer process if one contract manager is going to leave and another contract manager is going to go out. And by the way, that contract management could be a team. It's not necessarily an individual person. And those people should understand what the dispute resolution processes are. I mean, the whole point of doing the PPP is not, as Andre said, it's like a marriage. It's not to get to the divorce, right? It's to get to the counselor, to say, okay, we're having difficulties in our relationship. What do we have to do to resolve them, to ensure that the services are being provided? Because that's the ultimate thing that we want to do for the public. And also we need to ensure that the private sector gets adequate remuneration to make it profitable for them, because they're in the PPP not because they love you, they're in the PPP because they want to make a profit. And it's normally a long-term concession. And if I could say one thing about the dialysis project that was run in South Africa, I believe it was in Limpopo.
Limpopo, yes, it was in Limpopo.
Yeah, I mean, that was an excellent project. It worked extremely well. And it literally saved lives, right? And part of the problem when you do a healthcare PPP, well, any PPP, but particularly in the healthcare services, we've already done a PPP because we don't possess the skills and abilities to provide those services. And I think there should be some mechanism by which government is prevented from taking the project back when it couldn't provide the services in the first place. If you get my point.
No, I do, rightfully so.
Because basically in Limpopo, we're almost back to square one.
Yes, I heard that. And then, I mean, it was a state of affairs because, I mean, we had a 10-year contract extended for another 3 years. But I guess it is what it is. And I agree with you, you know, it should only be able to be taken over when you know that they can sustain what has been implemented from an infrastructure, quality perspective and good clinical outcomes to ensure that is maintained from a government perspective to say, okay, now you can run with this. And yeah, I believe they're now opening up satellites. So
yes,
let's see what comes out of it. Yeah,
they are doing that. And I think, I mean, I'd like to sort of have some feedback from the speaker, if I may, about so that the project was terminated. So, you know, what has it done for the quality of the healthcare services?
Hello, thank you. I'm not sure if I got the question well. Are you asking what is currently happening following the termination of the contract?
Yeah, so one would assume that the quality of healthcare services has deteriorated. No, I'm not being facetious. I ask you that honestly, because so that we.
Okay, this study that I conducted was not looking at the quality of care, but the challenges.
Yes.
But it would be interesting, as you're saying, for someone to get in now that the government has taken over and assess the quality of care, because like the other participants said, in terms of the records out there and the studies that has been conducted on the performance, on the quality of healthcare during Tsepo's management, the quality was rated to be good and high. But it would be of interesting for PPP health practitioners to know what is currently happening. I don't think there's been anyone who have come in now, but maybe they are there. But it's of interest to know. But so far, I honestly don't know what is happening in terms of quality of care since the government took over.
Okay, thanks. That's at least that's an honest answer. But you know, Andre's comment that in fact the quality of health services under the PPP was quite good, and I think one of the things that we should always keep in mind when we're looking at healthcare PPPs is, you know, companies like Netcare and other private sector companies, if you need a piece of infrastructure, right, a clinic or a hospital, whatever level hospital it is, they'll build the thing. But what they constantly make clear is they are not um, um, infrastructure maintainers. They make their money from clinical services, right? So one of the key lessons we have to learn is the quality of services is the infrastructure is merely a mechanism to deliver the services. And I think that's one thing that we should be very, very clear about. They're not interested in the building. Okay, it's not a head office accommodation. It's a service delivery mechanism. And one of the things is that I do find problematic is in terms of the unitary payment that was happening in Lesotho, the transparency with the private party should have been to say, look, this is exceeding what we thought that the unitary payment was going to be. How can we actually manage it to bring it back in line so that it's within the parameters of the contract? And I think, you know, from both sides, that could have been a way of looking at the issue instead of just saying, well, it's become too expensive.
Kogan, if I can just come in quickly, I think subjectively again, that at the heart of this project, the challenges was money. And the first major trigger, if I read it correctly, was at the stage 5, 6, 7 years ago, when Netcare claimed money for referrals to South Africa. And we know now that the referral system, and specifically the remuneration, the approval within the Department of Health, that system was not working properly. And I think that, to my mind, at least coming from a banking background, was the start of many problems, because Netcare claimed money for people that was referred, and there was not enough funds within the Lesotho system, health system, to actually pay for these additional. And there this record sort of started to gain momentum. And then from that, what happened is that in many cases, the Lesotho government was slow in paying Netcare. So they sometimes took 4 or 5 months. And I'm taking this information from a report that was done in, I think, 2019.
2019.
By the IFC World Bank group. So what that did is we also need to understand that these SPVs do not have a big capital base, so they cannot easily withstand negative financial impact. So when this happened, where the government was paying slowly, it nearly led to the bankruptcy of the consortium, and the consortium members did not always receive what was due to them. So you will get 10 Rand, 100 Rand coming in at the top, and that is got to go through a funnel, and everybody has got to get their share. And that's where the disrecord within the consortium then started to make waves. So to my mind, a lot of the problems was not necessarily the health services that was delivered or not delivered. It was more about, and that's my subjective view, it was more about the financial arrangements that did go askew, that didn't really benefit. On the one hand, the government, they battled to be able to afford, and on the other hand, it impacted very negatively on the consortium. Just that input.
Well, look, just on that point, you see, Andre, I have the, and again, this is my subjective view. I am of the opinion that you enter into a PPP with a country like Lesotho, where it's very clear that capacity and understanding of how the contracts work and how they should be managed should be one of the main things that you look at. But my point of view, again subjectively, is that the private party should have said to government, it is not affordable to refer these things to South Africa, right? So we're going to have to find a different mechanism, or we might have to extend the contract for a little longer to make a little extra money on the tail. So that's the responsibility of the expert, right? So if I go to hospital and I need to have a knee replacement and they can't do it for me here, they're going to have to say, well, we're going to have to find a different way of getting that knee replacement to be affordable, right? And I think that was the private party's responsibility, personally. But you're right, the issue was around cash. And it is not right for government not to pay for the referrals. But those things need to be spoken about and a solution found. Right? I think it's
Kogan,
yeah.
can I please come in there just to clarify one thing? What happens is that the contract between government and Tshepong excluded certain services that the private sector was not supposed to provide, but continue, just like before this new hospital, to refer them to Bloemfontein. So the invoices would not be necessarily paid by Tshepong, but directly from Bloemfontein, they would be paid by the Ministry of Health. So Tshepong was not paying for any referred patients because those patients would have been referred for services that were not included in their contract in the first place. That government has clearly indicated from the beginning that they will keep taking care of such services financially. But yes, this issue of late payments is one other issue that comes up every time as a contributing factor to high project costs, because the contract clearly stipulated that if by end of certain number of days, suppose it's 30 days plus maybe a grace period of say 7 days, after that, if I don't receive my payment, a certain interest will be charged. So because government, of course, in most cases found itself being behind with payments, the private party would be invoicing will be including the interest in their invoices, which are already adding to the cost of extra patients and the unitary payment. So other than the extra patients adding to the unitary payment cost, the other issue was delay in government payments. Yes, thank you.
Okay, so that's a good point, because you see, often in PPP agreements, failure for government to fulfill its obligations, i.e. Make its unitary payments on time, over time those are breaches of contract that can lead ultimately to termination of the contract, right? So this is very important, because when you enter into this agreement, you take on certain obligations. It's a contractual obligation that you pay the private party for the services that it requires. So one of the things that I'm not certain about is how the referral to Bloemfontein was done, Was the referral simply done, or did it have to go through an approval process within the Department of Health to see what the budgetary implications would be? Right.
Thank you for that. What on the paper was supposed to be happening is that the referrals needed the Ministry of Health approval. But what one learned is that at the beginning of this operation, when the operator wanted to refer patients to Bloemfontein, there would be delay due to those processes that need to be followed for the government to sign off. And then it ended up the operator doing that without government approval. That is one other thing that I know government has been complaining about, that Tshepong is referring patients to Bloemfontein without our approval. But from what one heard is that at the beginning of the contract, there were delays in those processes to get people approved. And if a patient is here and needs referral to save their lives, Tshepong ended up doing that on its own, and then that was not satisfactory to government. Thank you.
Yeah. So in that case, again, because I've not read the feasibility study, those costs, I would assume there would have been some sort of estimation of those types of costs that would have been built into the contract and built into the budget allocated to the Department of Health through the National Treasury or the Department of Finance in your case. But because of the lack of a PPP unit and of proper PPP skills and advice, there could have also been a way of saying, look, these things we know will be additional costs, and how will we account for them in the national allocation of the budgets, right? So, you know, one of the key things here is in a situation like this, you can't just say a PPP is the unitary payment is going to be $50 a month, because there will be additional costs, what we call pass-through costs, right, in many cases. And I think depending on your point of view, because I've been a public servant most of my life, you know, because these things are funded through banks and private investors, they need to get paid back for whatever their investment is. So, I mean, I think these are valuable lessons that we can learn about how these kinds of things are done, and particularly in developing nations, right, where we simply may not have the capacity to deliver certain services, even through a PPP. I mean, I hope my point is clear.
Yes, Kogan, we would like to give maybe the word to Mariana. She raised her hand, right? Mariana, would you like to comment?
Yes, please. Thank you. Good morning from Portugal. I'm very interested in this project because I used a case study which exists. I forget who prepared it, in a project finance class, and it was very helpful to explain what happened before, of course, these how the project was designed, because the last time I used it, it was well before these problems became evident, and so we really focused on the project design. One of the issues that I asked here is whether there was an issue of the filter clinic with the filter clinics, because the health sector is very complex to managing any situation, and the relationship between the primary health care, which that is supposed to filter the less serious conditions and refer only the more serious health problems for the secondary and tertiary hospitals, that is a key issue of managing and containing health costs and achieving health outcomes. Because I'm an economist, I'm not a doctor, but what I understand is that resolving health problems close to home is always generally better than having to send people to far away to successive referrals. Portugal has had quite a bit of experience with health PPPs. I was briefly working in the Ministry of Health of Portugal, though I was looking at it from the budget side. And I must say that in Portugal, the investment by the government in the PPP management was intensive. They spent a lot of money training people. They had top lawyers, and they had an office in the PPP hospital where they would go once a month to see everything, to review something like 200 indicators and so forth. In the end, because of the political changes that you described, which we've also had in Portugal, the health service contract was terminated. Portugal has a dual contract. So there's a PPP contract for the infrastructure, which is 30 years, and a shorter contract for the health services, which were 10 years, and those contracts have not been renewed. They were not terminated. There was no particular dispute regarding it. They simply were not renewed, because one of the things that was critical in Portugal was to achieve the transfer of health management skills from the private to the public sector. The private sector is still managing the infrastructure, keeping the lights on, etc., doing the services which were retained in the infrastructure contract. None of this was a perfect solution. There are no panaceas in health PPPs, in my opinion, or in PPPs in general. If the public service is complex, when it's provided directly by the public entity, it will be doubly complex when it is outsourced to most types of PPP contracts, because PPP contracts add a layer of a complexity which can actually increase the budget sustainability problems. One of the issues I wanted to emphasize right from the beginning, I heard our Madam Mofoka say that there was excess demand. This is expectable. Because when a brand new hospital appears, everybody wants to go to the hospital. So this is here in Cascais, which is the beach resort in Portugal. So the people already have a lot of healthcare. At first, they thought they might have had to build a whole third wing because so many people went to the hospital the first year or two, and so. Controlling production is key for health sustainability. And that is, so it's very interesting, this issue of the unitary availability payment and the excess production. In Portugal, it was the job of the Ministry of Health to keep production within the cap. So in any case, I'm very pleased, and I want to thank you all for this presentation. I think this deserves a revision of the case study for use in universities, because I think that still has a lot of very important lessons. Thank you.
Okay, thank you for your contribution. You see, sorry, but the differences have to be taken into account. right? So my assumption is, as part of the EU, there is universal public health care available to all citizens. Excuse me, and that's my understanding. If I'm incorrect, please correct me.
Yes,
So-
in Portugal, we have, it's not because of the EU, we have a national health service on the British model, which has existed for 30 plus years. And one of the complexities that we have, and we have it now, and we're having a health crisis, a health services crisis now, is that we have SNS, National Health Service hospitals, as well as private hospitals. And so doctors are moving, doctors are allowed to have dual service. And so they're moving from the public hospitals to the private hospitals. And we're having, even now in the summer vacation period, a lot of difficulty keeping the maternity wards, the maternity emergency services open in the public hospitals, because the doctors get paid more in the private hospitals for such service. So, so the PPP, as I said, is not a panacea, but it can be very helpful. And I'm not surprised to hear that health outcomes and the quality of health services improved. That's usually seen. If you don't manage the contracts well and you don't maintain budget sustainability, then you can lose those gains very easily.
Yeah, you see, so now again, very useful comments. Thank you very much. So if I could use the example of South Africa, because I used to work in the National Treasury and we used to report directly into the budget office, because PPPs were, we had to provide what we call sovereign guarantees for many of the PPPs in the country. So if something went wrong with the project, the Treasury was responsible for repaying any outstanding debt that was on the PPP. While we do have a public healthcare service in South Africa, and it is in one of our top 2 budgets, apart from, so the top 2 budgets in this country are healthcare and education, right? And yet we have the lowest outcomes from those budgets. So if you go to a completely public hospital in South Africa, the quality of the healthcare is less than shocking. You know, people line up all day to get access to healthcare. Sometimes there's pharmaceutical supply chain issues. The infrastructure in many of the hospitals is literally falling apart. So, you know, how exactly it's going to be done is still open to some debate, but the participation of the private sector is absolutely key. And there's no doubt that that's going to drive up costs. But with the existing budgets, much of it is mismanaged, because the people who are running the hospitals are not necessarily healthcare professionals themselves. And I'm not talking about the staff, I'm talking about the management of the hospitals. So that's why many people like me who are middle class, we have private healthcare and we use private healthcare facilities. We do not use public healthcare facilities. So one of the things that we found out is that the cost of running private healthcare facilities far outweighs the cost of running public healthcare facilities. In fact, more money is spent on private healthcare in South Africa than on public healthcare. And yet it's a much smaller part of the population that can afford private healthcare. And by the way, private healthcare insurance in South Africa is very expensive. So I've got a family of 4, and what would it be? We would pay something like 800 or 900 euros a month to have access to our private healthcare. So it's, I mean, it's a very mismatched environment. And we would like to have something like the NHS, which I believe is having its own problems in terms of funding and so forth. But in general, there's a pretty good quality of service being delivered to the people of the UK, which cannot be said for most of the environment in sub-Saharan Africa. Well, I would, and my guess would be in the rest of Africa. So we might need to find some sort of hybrids in order to deliver these services. So we're in a much more difficult situation, and we have the fastest growing population in the world on the African continent. So the need for healthcare facilities and healthcare services just keeps increasing.
Yes, right. Thank you, Kogan. I would still give some few minutes to those who raise hands, because we're out of time. We are about.
I just want to apologize because I can't see where the hands are being raised.
You can go to chat and open, and then you can see those who raise hand. I see that Aloy raise his hand. Let's give some few minutes to those who would like to comment, and then we will finish. Okay. So let's. Mariana already commented. Now Aloy, please unmute yourself and yeah, please go ahead. Hello, can you hear me?
Yeah, hello.
Yes,
Okay,
please.
Yeah, can you hear me? Huh? Hello.
Hello, please speak.
Yeah. My main intervention is a regard about the project for the Lesotho hospital, and what I used to analyze is the country and the people has been let down, and from my own perspective, both sides need to take responsibility of the failure of the project, like the public sector or the private sector, and risk has been really undermined about the PPP project, and the case is like hold up contract has been used by the private sector to make a huge amount of benefit of a return payment or get advantage of the public sector who have no clue about PPP contract or how the different step of the PPP management we're gonna to be managed from the beginning, as well as soliciting contract come forward, because identification of the projects and the selection of the project, and then we're moving to the next step where feasibility study will come out, see how material will cost. The tendering, the procurement process as well has been undermined regarding the transaction advisor, how tendering bid has been all around organized, and then move to the last step about monitoring the hospital instead of even regarding the proper contract. So lesson to be learned to see what the effectiveness and the efficiency of the PPP can be revised, and mistake will not be made to the next future project in the hospital in Africa. That's my opinion that I was trying to add to the presentation.
Thank you. Thanks very much.
Yeah, I'm done. I'm done now. I'm done.
Are you done? Okay.
Yeah.
All right. So unless there are any sort of quite urgent points or comments people would like to make.
And we still have Oksana Aboska who would like to comment. Oksana, please. The floor is yours.
Thank you, Dinara. Thank you. Hello, everyone, and thank you very much for organizing the discussion. I had been following these hospitals from its beginning, and I know that there was a case study by IFC and World Bank itself, which is publicly available, by the way. Yes. And the major problem with the contract was that there were no cap put on the number of cases to be served. So what happened is, as Mariana truthfully underlined, as soon as a new hospital had been opened, everyone wanted to go to the new hospital. And as there were no cap and the price per treated case was exactly the same as estimated cases, the cost went up. And at that particular moment, the government changed. So a new government was not aware why the costs were accelerated. This is lessons learned, not only for Lesotho, but for all the professionals working in health sector, and especially in Africa and Asia, where the resources are very scarce. So now all the contracts in health sector should have a cap of where the unitary payment is applied, and if the cap is exceeded, then another amount will be used. And this is now, for example, in the contract in Uzbekistan for the radiology services. This is very well reflected. Also, what we should not underestimate, when, for example, we know that in Africa there are many hospitals and many facilities which are run by faith-based facility or NGOs. Can you hear me?
Yes.
Okay, which are running and are being financed either by public service or by the private payments. In case of Lesotho, a patient preferred to go to public facility where they received the service free of charge instead of to pay the outdated facility, faith-based or NGO-run facilities. And that was also, and this I would really like to hear from our colleagues from Lesotho, because there was a lot of discussion from the faith-based organization that the government is, instead of supporting them or finding different reasons, so this case with the faith-based facilities was not very well resolved, which led to a lot of discussion and a lot of negativism, let's say, in the community. Thank you very much.
Thank you. That's an interesting question and point. So would our presenter like to take a stab at that?
I'm sorry, Kogan, can you summarize what the question I had is about the faith-based organizations?
So there wasn't, because there hasn't been much discussion about other forms of healthcare service delivery. And one of them, two of them could be NGOs or faith-based organizations, and how those could be incorporated into the delivery of healthcare services.
I hope I'm getting the comment well, or the question, but what is currently happening in the country is that when the government implemented free.
So I need to go back where I was. No problem.
Sorry. Okay, thank you. I was saying when the government implemented the free healthcare services policy in 2008, it entered into a memorandum of understanding with all Christian Health Association of Lesotho facilities, such that the government subsidize, not the, provide the facilities with what we call subvention to provide healthcare services. That was an effort to ensure that every Lesotho, wherever they are, they can access healthcare at the same cost, despite whether the nearest facility is the Christian-run facility, child facility, or is the government facility. That's what the government did in an effort to address the issue of access to healthcare services to every citizen.
Okay, that's good to know, because I think there are throughout the world many faith-based organizations that do help provide healthcare services. But I think, you know, again, this is my personal point of view, even if the services are there or people can access the services, in my mind, it's the quality of the services that are provided to our citizens. And, you know, this is a human right. It's, you know, it's not something that should be seen as a privilege, like access to a decent education. So I think the thing is to try and find sustainable ways of taking the resources that we do possess and increasing the quality of the healthcare that's provided to our citizens. You know, because even though I'm a South African, my father was in the anti-apartheid movement, so I ended up growing up in Toronto, in Canada. And my healthcare services were completely free. I could walk into a hospital and get first-class healthcare. And honestly, in my mind, it was the superior management of the resources that existed that allowed quality healthcare to be provided to the citizens of the country. So that's my personal view. So I don't know if there's any comments on that, or if we can ask Dinah if we can bring the session to a close.
I think we are going to conclude. Kogan, would you like just to, you and Ntoetse very fast, just to say some few words, and then we are going to finish.
Would you like to go first?
Yes, please. Thank you very much, Dinara, and once more thanks to the invitation to share the lessons from this hospital with the community. But as indicated, let's try to prepare our health sectors or any sector that we enter into. But since this platform is mainly about health PPPs, let's try by all means to prepare the sectors very well, because failure to do that, I think, is one of the reasons why Lesotho Health PPP project ended where it was, because I sense from the findings from this research and the comments from the people that I interviewed that we were not prepared, the sector was not prepared, the country was not well prepared. So I think that is one major takeaway, that let's prepare, let's be patient. After all, PPPs are already taking long time to prepare, so we might as well take advantage of that and prepare our sectors and countries properly to undertake these complex projects. Thank you.
Yes, well, thank you to all the participants, and thank you very much for your excellent presentation. It was very illuminating, and I think it's important, specifically about projects like the one that you presented on, that we really try and understand what the challenges were, and as you said, the preparation, and how we use our resources so that they are not used as a political tool to say, well, look at healthcare PPPs, they don't work, or they're too flawed, or Africa is not ready for them. Because the intervention of the private sector is absolutely needed. And I also think that we should be very careful when we are looking at which services we are going to, in the output specifications, let the private sector provide in order for us to maintain our budgetary constraints. And I'd like to thank Dana and PPP Health4All for organizing this. I certainly learned a lot, and it was my pleasure and my privilege to be introduced to new colleagues who have worked in the sector. And I hope we can have another workshop like this, where we can determine a specific topic, and then have a presenter and a good discussion, because I think our discussion was very good today. So I thank you all. And I don't know if you would like to make a few closing comments too.